Southern Tier HealthLink is a health information exchange located in upstate New York. It was formed in 2005 primarily by the major hospital systems and local physician organizations. We've decided to put ourselves in the role primarily due to lack of really resources in our area that are very up on this type of thing. So we've decided to act in the role of outreach agent primarily, which is to be a place where everyone can come together to collaborate with each other, get mentoring. We can hook them up with the proper type of resource that they might need, and we do a lot of education. So we hold seminars. I'm in the community all the time talking to groups, and just did one at the State University group on workforce development. That's a big issue I see moving forward. There's just not enough skilled workers in this area to accommodate the needs. So we really need to support those groups. So that's how we see ourselves primarily, is in coordinating with the state rec agents and our local community. We have been on grants. We started with the New York HEAL program back in 2005 with HEAL 1, and then subsequently won the HEAL 5 award. And we have been all along collecting fees from our member organizations, towards sustainability, which will somewhat increase as we get off the grant cycle. But in addition to that, we're actively involved and hope to come to a conclusion quite soon with the 3 major payers in our market who recognize the value of the services we provide. There's been a few different payer arrangements that have been made in the state of New York. So we've looked at different models and engaged the payers in conversation, and they really are now coming out on the side of keeping it simple. We're not looking for money for capital investment. Most of our investment, if not all of it, in developing products and services has been covered by the grants. What we're looking at is the ongoing operations and sustainability components. So right now we're looking at a simple percentage of our annual operating expenses to come from that sector. We've developed these things years ago before anyone ever heard of meaningful use or ACOs or patient-centered medical home being such, a large project that's going on around the country. So we really focused on clinical input. What can we do to make your workflow better? What can we do to improve the sharing of clinical information to improve care? And looked at a lot of workflow hiccups. So, for example, one of our top projects is, service-wise, is the ability to send electronically referral information from one electronic medical record to another, even from one from a outpatient environment into a hospital environment. Today, even though they may both be using EHR, that becomes a fax to one party or the other, and then someone has to sit there and data enter that. So that's a service we offer that physicians find very valuable and are willing to pay us for it. In addition to that, the Master Patient Index. We're working right now in a test environment to send back a clean EMPI to our major hospital systems to help them with an issue everyone has, which is duplicate medical records, and the big financial cost that costs an organization and lost billing opportunities. It's actually how we started this project way back in 2004. We had, at the hospital that I worked at then, we had a pretty robust patient solution, but it was empty of information and patients had to put it all in. And we kept getting requests from patients like, the expectation was, you've got that information, give it to me. So we started to look at how can we do it, and we realized the information came from all these places, so we first had to gather the information, aka Health Information Exchange. There's a lot of rules and laws out there between state laws and federal laws, and a lot of disconnects in what patients can see and what they can't see. So we're starting out small. We've already got a portal up where patients can go in and see who's looked at their record in the HIE. They can change consent electronically, so they can change it every day if they want to for different providers. And we're working with companies like Microsoft Health Vault to enable the information in the HIE to move over there, and companies like NextGen that have electronic medical records with a PHR attached to it, to get them to start to give the patients more access to information. But it's we're in a strange time right now with differing requirements that the vendors are paying attention to that may not necessarily be directly focused at patients right now, because it's not a meaningful use requirement right away. So they're trying to work on their products to meet the things that the larger majority of their customers need. But I think we're going to start to see in future iterations that this is going to really be the way that we need to go. So we're out there trying to get this adopted early. I think, two of the big issues that I see, if I had to narrow it down to two, is consent. It's very expensive to get consent. It puts a lot of cost into the health information exchange. It's certainly necessary, but I think we've seen some recent reports coming out that the opt-out method is much less expensive, and it also encourages adoption of the usage of it by clinicians. I mean, logging in and finding out that your patient hasn't consented yet, so you can't get the information. You'll do that a few times and it starts to become a burden to even bother to use the resource. And secondly, I think one of the things we've done early on, and I think a lot of folks are starting to do it, is to stop trying to get everybody to log into a portal. Connecting in the workflow. If they've got an EMR, we've got a way now that they're able to connect to us bidirectionally. And it doesn't take them remembering a username and password, it just gets into the workflow. And workflow eats technology for lunch every day of the week. So that's how I see two of the things that people really need to start to focus on.